Hello and welcome to the last video in our Chapter 38 video lecture series. In this video, we are going to talk about cancers of the esophagus, the stomach, our colon and rectum, the liver, gallbladder, and the pancreas. So we'll start off with the esophagus. And the types that are the most prevalent within the US are squamous cell carcinoma and adenocarcinoma. Our squamous cell carcinoma is going to be associated with tobacco and chronic alcohol consumption. You could see the change within the tissue as it progresses into invasive cancer here. And this really is within the mucosa of the esophagus. Adenocarcinoma is going to be associated with obesity, GERD, and smoking tobacco. And we can see that it's really within the glands within that area and is made up of the columnar glandular epithelium. It's often secondary to gastric carcinoma or Barrett dysplasia, which is also known as Barrett esophagus, where the mucosal lining is going to become abnormal and more like the intestines. And it can progress to metaplasia, a precancerous lesion, and some of the frequent symptoms are going to be chest pain and dysphagia, but most common pain is going to be heartburn. To diagnose this, we want to use endoscopic ultrasound and CT studies of the thorax, and this will help to stage the cancer as well. And for treatment, we want to remove the primary lesion and the local lymph nodes, which can benefit the patient, but sometimes we also need radiation and chemotherapy. Now let's move into cancer of the stomach. We can also call this gastric adenocarcinoma, and this typically is going to be associated with atrophic gastritis and Helicobacter pylori infections. And we tend to lose the tumor suppressor genes and other genetic alterations that make this come about. We do see an increase in people who are going to consume heavily salted and preserved foods, such as nitrates in pickled or salted foods, such as bacon. You also want to think about all those different dried meats. So if you love a good charcuterie board, you got to kind of watch out. And people that have low intakes of fruit and vegetables and use of tobacco and alcohol. Now you might be wondering, how do heavily salted foods increase our risk of gastric adenocarcinoma? And that's because salt is going to enhance the conversion of nitrates to carcinogenic nitrosamides, and that damages the DNA of mucosal cells, and the nitrites within the food can cause delay in gastric emptying and can cause chronic atrophic gastritis, which can then lead into cancer. So the symptoms are going to be vague, such as loss of appetite, malaise, and indigestion. And then the later symptoms of unexplained weight loss, upper abdominal pain, vomiting, change in bowel habits, and anemia can come about. But usually the first manifestations of carcinoma are caused by distant metastases. So the disease has already progressed and is more difficult to treat. Now let's talk about colorectal cancer. This is the third most common cause of cancer and cancer death. Luckily, it is declining because of successful screening programs, but it is happening and being diagnosed in younger individuals, which is a concern. Most of this type of cancer is sporadic or associated with family history of colorectal cancer, and it's caused by multiple gene alterations and environmental interactions. We can have our familial adenomatous polyposis, and this is when we have a mutation of the APC gene. APC stands for adenomatous polyposis coli, which is a tumor suppressor gene, and it's the most common hereditary cause of colorectal cancer. The other type is going to be hereditary non-polyposis colorectal cancer, or it's known as Lynch syndrome, and this is associated with DNA mismatch repair, and that's why we call it the MMR genes. Now, the polyps that come about in the colon are going to typically be benign, but they can be adenoma and progress to carcinoma. We have our colorectal polyps, and these are typically going to be associated with cancer. We see that it's a projection from the mucosa, can either have a little stalk or be flat and up against the mucosa. And if these are adenomatous, then it's going to be neoplastic, which are premalignant lesions. And if they are larger, they do have a greater risk of becoming cancerous. The symptoms are going to depend on the location, the size, and the shape of the lesion, and tend to be silent in the early stages. For diagnosis, if someone has the hereditary polyposis, then they are going to start screening early on with colonoscopy and remove the polyps when we find them, and can also use the fecal occult blood test and fecal immunochemical tests. For most people, we're going to start screening and doing colonoscopies at 45 years old, and we want to repeat that every 10 years. Now, if someone has colorectal cancer, then staging is going to involve imaging and operative exploration. And operative staging can be done during surgery or a biopsy to see if it has metastasized. For treatment for all the stages, it's always going to be surgical, and then we can use chemo or radiation to shrink the tumor before the surgery and also after, to make sure nothing microscopic has been left behind. Sometimes resection is needed. Now let's discuss cancer of the liver. This is the leading cause of cancer death worldwide, and usually it's going to be caused by metastatic spread from a primary site somewhere else in the body. So the first type we have is hepatocellular carcinoma. This is going to be closely associated with chronic hepatitis and cirrhosis. We see that it's going to develop within the hepatocytes, and the cancer starts to invade the hepatic and portal veins, and often is going to spread to the heart and lungs or other sites such as the brain, kidney, or the spleen. Now, the patient may be asymptomatic or have vague symptoms such as nausea and vomiting, and because this cancer can invade the hepatic and portal veins, it can cause portal hypertension and progress into ascites as well. The other type of cancer we're going to have is cholangiocellular carcinoma, and this is very rare. It happens in less than 1% of the liver cancers, and is going to develop within the bile ducts. We start off by getting sclerosing cholangitis, which is a rare autoimmune disease that's typically associated with ulcerative colitis that we discussed in the previous videos. As far as the clinical manifestations of this, we'll commonly see insidiously presented as pain, loss of appetite, weight loss, and gradual onset of jaundice. And sometimes it can cause a rupture to take place, and we can have some hemorrhaging as a result. The diagnosis is going to be based on clinical manifestations, laboratory findings, imaging, and exploratory laparotomy. And surgical resection is possible only if that tumor is localized, so that we can remove a lobe of the liver. Some other therapies are going to be chemoimmobilization, immunotherapy, and radiotherapy for the patient. Now let's move into cancer of the gallbladder. Now, cancer of the gallbladder is rare and it's associated with larger gallstones. Most gallbladder cancer is going to be caused by metastasis, and we see that most are going to be adenocarcinomas, and more rarely we'll see squamous cell carcinoma. It's usually going to be due to several genes being mutated, including a lot of the tumor suppressor genes and oncogenes, and our DNA repair genes, or we have alterations taking place within the extracellular matrix. And that liver is going to start to invade the liver, the stomach, and the duodenum. We see chronic inflammation taking place, and it triggers dysplasia to progress into metaplasia. In the early stages of this type of cancer, we are typically going to see the patient being asymptomatic, But as those symptoms start to develop, there's usually going to be a steady upper right quadrant pain for about 2 months. Other manifestations would be diarrhea, belching, weakness, loss of appetite, weight loss, and vomiting. As that tumor starts to enlarge, it can also obstruct the biliary ducts and cause obstructive jaundice to take place. So we usually find it in the late stages because, as you just heard, there's a lot more symptoms all of a sudden happening, and that may prompt one to look at the gallbladder, especially that upper right quadrant pain. And here's an ultrasound where we can see that cancer, that tumor growing within the gallbladder. So diagnosis is usually there's another type of inflammatory disorder being evaluated and we find this, or it has progressed and we like I said, did some imaging in the area of the gallbladder. For treatment, we can do complete surgical resection of the gallbladder. It seems to be the only effective treatment, and we can add chemotherapy if it's in its advanced stages. Now let's talk about cancer of the pancreas. This is the 4th leading cause of cancer death in the U.S. Unfortunately, we don't know the cause, but we know that tobacco smoking, certain dietary factors such as having a high-fat diet and eating processed meats could increase one's risks. Being obese, having diabetes, chronic pancreatitis, or family history of pancreatic cancer, having Lynch syndrome, which is colorectal cancer, and several oncogenic and tumor suppressor gene mutations will all increase one's risk. So we have the pancreatic cancers being able to arise from both exocrine and endocrine cells, but most of the time we're going to see cancer arise from the metaplastic exocrine cells in the ducts, and it's going to be called ductal adenocarcinoma. The chronic stage of pancreatitis and inflammatory cytokines help to support tumor growth, and if that tumor is within the head of the pancreas, it can quickly spread to obstruct the common bile duct and the portal vein, which you can imagine leads to things like obstructive jaundice or portal hypertension. And these tumors can also infiltrate the superior mesenteric artery and the vena cava and the aorta and form emboli. If the tumor is found more within the body or the tail of the pancreas, it can infiltrate the posterior abdominal wall. Now, when this cancer first comes about, it tends to be asymptomatic, but when the symptoms occur, there's usually, like we said, an obstruction and a malignant transformation. And typically we'll have some symptoms that are vague, such as upper abdominal pain that can radiate to the back or shoulders. And as this cancer spreads and affects our lymphatic and circulatory systems, we can find metastases within the cervical lymph nodes, lungs, and brain. Laparotomy is usually going to be used to be able to diagnose and evaluate the extent of this disease, and we can also determine if we need palliative bypass surgery. Sometimes we need the Whipple procedure, and this is when we perform a pancreaticoduodenectomy in order to decompress the duct obstruction, and a lot of surgeons recommend a total pancreectomy.